All right. Thank you very much, Dr. Cooper, for that very, very interesting talk and
Thank you.
enlightening talk.
My
We
pleasure.
have a few questions from Delhi. First is from Dr. Devesh that basically we're talking about the replacement dose of levothyroxine. It's around 1.6 microgram per kg. So would that be, the dose for all patients? For example, a post-surgical hypothyroidism in which the total gland has been removed, probably after radioactive iodine therapy also,
Yes.
versus a patient who's got early Hashimoto's, wherein some gland is functional. Probably the dose would be probably different in both of these, or you'll just start with 1.6 in a young patient.
No. So if a patient has has some intact thyroid function, you could give the person 1.6 micrograms per kilogram per day. That would just completely replace their thyroid function. So you could do that, or as many people do, you could say, well, let's say 50% of their thyroid is still there. You could give them just half as much that they might need, and that would also restore normal thyroid function. And then you'd have to monitor the person because periodically their thyroid would progressively fail, for example, and the dose may need to be increased. Yeah, I didn't mean to imply that everybody has to be treated with the full replacement dose if they haven't had a thyroidectomy. I mean, certainly you could start out with the lower dose and then progressively increase it if need be over time. Yeah.
The second question is that we see a lot of patients with CKD who would come to us with a thyroid profile. They will get a full thyroid profile, FT3, FT4, TSH they've got, are waiting for a renal transplant, for example. And the nephrologist would send the patient to us, whether the patient needs replacement or not. So would you be happy to, because a lot of things in CKD, for example, metabolic acidosis, malnutrition, inflammation, proteinuria are going to change the thyroid profile. So what would be your advice? How does CKD alter the thyroid profile, the thyroid function? And when would you like to treat a patient of even subclinical hypothyroidism when the patient has CKD?
Yeah, that's a great question. And there's not a lot of data on this. I just can tell you that it's my impression that chronic renal disease does not really change things very much. I mean, it may be that if patients have extreme proteinuria, maybe there's some thyroid hormone loss in the urine, but that would be more of a patient who's already on levothyroxine. So if someone is, let's say, on levothyroxine, they have nephrotic syndrome, you can lose a lot of thyroid hormone in the urine because it's bound to TBG. So the dose may need to be increased in people with nephrotic syndrome. But let's say a person is just on dialysis or they have chronic renal disease, that things really don't change that much. So I think, yeah, you just do whatever you think would be appropriate for that patient.
So if you have a patient with CKD waiting for transplant, the T4 and T3 are in the lower quartiles, and your TSH is just about touching 9, because a lot of data from nephrologists would argue that if you treat this patient, you increase the renal blood flow, and probably the chances of rejection also decrease when you treat a patient such as in the lower quartile of T3, T4.
Mm-hmm.
What would be your opinion?
You know more about that than I do. Honestly, I can't even answer the question. Maybe the nephrologists are right. I mean, let's face it. We're not talking about starting some horrible drug that has lots of side effects. I mean, it's pretty innocuous. So if the nephrologist thinks it might help the patient, I would do it. It's not going to hurt the person.
Because sometimes their argument is they have seen patients of clinical hypothyroidism with proteinuria. If they get the TSH down, the T3, T4 in the higher quartiles, probably the proteinuria disappears.
I'm not aware that is the case. But thank you for telling me about this, because now I will research this and yeah, if there are any references you have, you could send them to me. I'd like to read about that. I'm not aware of that.
So another question from Dr. Praveen. Your focus in the presentation was only TSH, but probably because in our country, all our patients would get back to us probably with the FT3, FT4 TSH all the time. So do you think it's only a TSH that is important, or a full profile may help more deciding the therapy, and probably with the clinical features like heart rate, weight loss, anything like that, with a full profile would be more beneficial as compared to TSH? The second part of the question is, if you have a patient with normal TSH, but the T4 is high on levothyroxine therapy, would you like to alter the dose, or you'll keep the dose same?
Okay, to answer the first question, as much as I hate to say this, I think getting the TSH only is adequate. And I think it is much more cost effective. It doesn't really matter what the T4 and T3 are. If we're using the TSH and the pituitary gland as our judge of what is normal for that person. And granted, maybe that's not valid, but if we're using the TSH as the judge, it doesn't really matter what the T4 and T3 are. I mean, you could say, well, gee, maybe the T3 is on the low side. That might justify giving T3 therapy plus T4 maybe, but I don't think it matters. And in terms of the high free T4 and a normal TSH in someone taking levothyroxine, we see this a lot. And it's hard to explain, but I would not decrease the dose just because the free T4 is high if the TSH is normal. There may be, as you get more and more T4 in your body, the conversion of T4 to T3 actually goes down. And that can lead to the T4 being on the high side or even above normal, even though in that same person, I guarantee it, the T3 will be on the low side.
All right. So a question from my side. Do you think you can expand the indications of T3 to, for example, a patient with hypothyroid coma in which you want early recovery, you want to make the patient better, in which hypothyroid coma would have decreased T4 to T3 conversion. So probably T3 would be an indication in hypothyroid coma. Probably a patient taking steroids, again, T4 to T3 conversion goes down. A patient with sick thyroid syndrome, inflammation and interleukins decreasing T4 to T3 conversion. A patient with central hypothyroidism, because we know that TSH increases conversion of T4 to T3. So patient with central hypothyroidism will do better on T3 versus T4?
So just one last point. TSH doesn't increase T4 to T3 conversion. I don't know. That's not the case. But for all those other reasons you were talking about, yes, this is really important. And, there are no randomized controlled trials comparing levothyroxine alone versus levothyroxine plus T3 in mixed edema coma. Some advocates recommend starting T3 and T4 therapy at the same time in people that are, critically ill with severe hypothyroidism. Other people think it's better just to give T4 alone, and then if there's no clinical improvement, add T3 in a few days. The reason people shy away from T3 in illness and starvation is because this is the body's defense mechanism. In other words, why is the T3 low if someone is sick? It's because you don't want a lot of T3, because T3 is a metabolically active hormone that just increases your metabolism. So the body, in its wisdom, is doing this. So the idea of saying, oh, the person, is critically ill, let's give them some T3, that's not necessarily the right thing to do, except in critically ill mixed edema coma. Yes, that would be reasonable. But let's say a person is in the hospital with heart failure, pneumonia, renal failure, and their T3 is low. That would not be a reason to give them T3. It just might make them worse.
The last question from the Delhi team. Dr. Shashank has a question that there are some papers that suggest maintaining T4 to T3 ratio of 6:1 when combining T3 to LT4. But because measurement of T3 is difficult, short half-life, are there any practical or clinical parameters like heart failure that can help you decide the dose of T3?
That's why I said there are all these recommendations, but the easiest thing to do is just assume that 5 micrograms of T3 is approximately equal to approximately 20 micrograms of T4, 15 to 20 micrograms, and then just substitute that amount of T4 with T3. I don't know. There are other ratios of, molar ratios and the secretion rates and that sort of thing, but it's just too complicated. So no, I don't have any other advice. Yeah.
All right. Thank you very much. That's all from the
Thank you.
team.
Thank you so much for your attention. Enjoy your evening.
Okay, it's a pleasure listening to you,
Thank you.
Professor Cooper. I think we have got a lot of questions, some of them being covered by Mumbai and Delhi team. So whichever not been covered, I'll be asking. Is it still practiced a full starting dose of L-thyroxine or a stepwise increase on which clinical situation?
Yeah, I think that in younger, otherwise healthy people, it is perfectly fine to start on the full replacement dose. I can't tell you how many people I see who are, 20 or 30 years old, and their doctor has started them on 25 micrograms of levothyroxine a day when their TSH was 60. And now they're seeing me a few weeks later and their TSH is 40 and they're not feeling any better. There's no reason to start low and go slow in a healthy person. Only in an older person or someone with cardiovascular disease would you have to worry about that.
Is there any cutoff for a TSH or a total T4 in surgical fitness patient? You know that if person is called for a surgery and TSH is high, you need to wait for 4 weeks or a 6 weeks. Is there any cutoff where we can give a surgical clearance?
That's a great question. All I can say is there are studies of people that have gone to surgery before they had thyroid tests, and then they came back, and it turned out the person was hypothyroid, and nobody knew it. And then but they went to surgery anyway, and the outcomes are really not that different from euthyroid people. So I would say that if the surgery really needs to be done, and the person was basically feeling okay, and they weren't profoundly hypothyroid, it would be fine. But if you want a cutoff, I guess I would say if the TSH is less than 20, it would be okay for them to have surgery.
I think that's a great answer. That's how much weight loss we can expect in somebody is obese hypothyroid?
Somebody who
is obese and overt hypothyroid. Weight loss, how much percentage of weight loss we can expect with L-thyroxine therapy? That's
0. Well, no, I'm kidding. I mean, this idea that hypothyroidism causes obesity is just not right. It's possible that a person might gain, 5 or 10 pounds if they become hypothyroid, and so that would be expected to change. But the person is not going to lose a tremendous amount of weight if they are markedly overweight.
Do we have anything known as a L-thyroxine enhancers, absorption enhancers?
That's a great question. No, I don't know of any. I wish there were, but no.
And which are the clinical situation where we can just ignore mild increase in TSH?
Those are all the clinical situations. In other words, if a person has a TSH of 5 or 6 and they're feeling okay, I wouldn't treat that. The only exception I would make would be a child or a pediatric age group. I think those people should be treated just because we don't know what the outcome would be in a kid who is in school, and maybe it would improve their performance or their health in some way. But for an adult who has a TSH that's slightly elevated and they're feeling okay, I would not do anything to treat that except to monitor their TSH. Again, the other exception would be if they have a goiter or if they've had thyroid nodules. There are data to show that thyroid cancer is more prevalent in people who have Hashimoto's thyroiditis, and the prevalence of thyroid cancer is linearly related to their TSH, even within the normal range. So I would, if before I decided not to do anything, I might get an ultrasound and see if there are nodules in the thyroid, and if there were, even if the person was feeling okay, I probably would treat them.
How fast we should bring down the TSH in a pregnancy? What's the timeline? Somebody with overt hypothyroidism, how fast we should bring down?
As soon as possible. I mean, you want to correct this as quickly as you can. I mean, there's a higher rate of miscarriage, mainly in people that are hypothyroid. So I think if the person is profoundly hypothyroid, let's say the TSH is 30 or 40 or 60 or whatever it may be, you want to start off with the full replacement dose plus extra because they're pregnant. Remember, in pregnancy, the dose goes up by 15 or 20%. So you might calculate what their full replacement dose is and add to that even.
I think major food restrictions in a patient with hypothyroid.
0.
Yeah.
I'm not aware of any. I mean, there are, certain people think that large amounts of soy may impair the absorption of levothyroxine, but no, there shouldn't be any food restrictions.
Yeah, I think there is one more last question. Is iodinization is a boon or a bane for a thyroid?
Iodine?
Iodinization, is it a boon or a bane for a thyroid?
It's a boon.
Okay, fine.
Who would be asking that?
Yeah.
How could it be a bane?
Yeah. The only thing they are telling this because of iodine, we are seeing more and more of a hypothyroid autoimmunity. That's
yeah. Well, but you need to have iodine in your diet for your brain to develop normally. So I think we'll take that as a side effect, maybe. Yeah.
Okay. Thank you
so much. Okay. Take care.